Hello, and welcome to Alternative Models to Address Quality Care for Children with ASD. My name is Megan Hudson. I'm your introducer from the state of Indiana. Our group is comprised of Maria Dino from Pennsylvania, Selena Sizemore of Florida, Maribel Khan from Florida, Jocelyn Stone from Connecticut, and Lindsay Conroy residing New Hampshire. We're going to first have Maria Dino present her side for the favorable side of applied behavioral analysis. Maria?
Thank you, Megan. Hello, my name is Maria Dino, and as Megan has stated, I am providing research for the pro side of applied behavior analysis. The first point I'm going to go over is regarding the responsible conduct of a behavior analyst and reliance on scientific knowledge. (1.10) Reliance of scientific knowledge states that behavior analysts rely on professionally derived knowledge based on science and behavior analysts when making scientific or professional judgments in human service provisions or when engaging in scholarly or professional endeavors. Today, ABA is widely recognized as a safe and effective treatment for those diagnosed with autism. For the next few points that I will be talking about, there will be pictures that coincide with the literature that was researched using the article titled Applied Behavior Analysis is a Science and Therefore Progressive, and a website that was www.dealwithautism.com. Applied behavior analysis is a science and therefore involves progressive approaches and outcomes. In the article, they argue that the spirit and the method of science should be maintained in order to avoid reductionist procedures, stifled innovation, and rote, unresponsive protocols that become increasingly removed from the meaningful progress for individuals diagnosed with autism. ABA is defined as progressive. In a progressive approach to ABA, the therapist employs a structured yet flexible process, which is contingent upon and responsive to the child's progress. For children to make the most meaningful gains, both early and intensive behavioral interventions are required. This will be referred to as EIBI. The most commonly implemented and supported intervention for individuals diagnosed with autism are models based on the procedures developed and evaluated within the field of ABA. Researchers have shown that when children receive early intervention and intensive behavioral intervention, they make meaningful gains and certain percentages are able to become indistinguishable from their peers. EIBI is most effective when certain factors are in place. First, the intervention must be implemented with the correct dosage or intensity, meaning the intervention should occur a minimum of 10 hours and a maximum of 40 hours per week. Second, it requires the treatment to be comprehensive. Researchers have evaluated components of comprehensive treatments in various studies to increase language development, social skills, self-help skills, academic and leisure skills, and also play skills. Third, it requires the staff to be adequately trained. And lastly, when all these components are present, the results can be life-altering for a child diagnosed with autism. The next topic discussed is a very important component of ABA. This component is called reinforcement. The delivery of reinforcement is a core component of ABA-based procedures and is one of the key components for increasing and maintaining desired behaviors. It is important that a therapist who is implementing quality ABA be able to identify potential reinforcers, condition the item to be reinforcing, and implement reinforcement procedures on an appropriate reinforcement schedule. There should be a strong focus on being able to establish a wide range of conditioned reinforcers and to be able to effectively and efficiently access them. And if something is not as reinforcing, try to make it a little more reinforcing. The checklist that I have provided here, it is one of the better checklists that are out there. They refer to these as the golden reinforcers checklist. While they may be helpful, they are not the end-all be-all. They talked about conditioning in-moment reinforcers as well. One of the most researched and biggest contributions to the field of ABA and ASD has been the support of a functional analysis. Today, most of the research on functional analysis occurs in a setting such as a hospital or a clinic, as opposed to an individual's natural environment. A functional analysis or functional behavior assessment that is conducted within the natural environment would allow for better evaluation of how the individual's environment affects his or her behavior. A second characteristic of a quality program is ensuring that therapists know the function of the behavior and how to prevent those behaviors from occurring. An example of how this is done is by altering the antecedent conditions to make the reinforcer more available and predictable, and by teaching alternate behaviors to access the identified reinforcer. The last part of the process should be ensuring that the reinforcer is not maintained by the behavior, and that the reinforcer is not available when the child is engaging in a behavior. With that being said, identifying the consequence and maintaining or extinguishing the problem behavior is critical. Next, the article talked about how you are supposed to implement these behaviors. Training. Discrete trial training is a method of teaching in simplified and structured steps. Each step is broken down and built up using discrete trials that teach each step one at a time. Behavior principles are used in one-on-one settings to increase appropriate behavior and decrease inappropriate behavior. Skills often targeted in DTT, discrete trial training, include attending skills, imitation, receptive skills, expressive skills, and pre-academic skills. During discrete trial training, you are systematically teaching, for example, matching pictures, identifying an object, measuring those skills by collecting data. Learning is fostered through repetition, and skills are taught in isolation and in their smallest, most form necessary. And this helps implementers maintain consistency throughout. So I have an example here of a discrete trial. It's a trainer and trainee. They put the toy on the table. The trainer says touch. If the trainee touches, you give the student 1 to 3 seconds to respond. If they do touch, you give them a good job, a sticker, whatever it is. And then you take the item off the table. What separates ABA from other approaches is reliance on objective data and measuring observable events. When implementing procedures based upon the principles of ABA, therapists should take data to track a student's progress. There's not really a one-size-fits-all. There should be a variety of measurement systems that can be used, such as trial-by-trial data, time sampling, and probe trial data. Data should be useful, be worth the time taken away from other activities, and not interfere with teachable moments. And they should also not compete with social interactions. The next topic that was discussed was curriculum. Children diagnosed with autism typically have several deficits, and therefore the curriculum should be addressed. You want to reduce inappropriate behavior as well as teaching learning how-to skills, social skills, language, play, self-help skills, communication skills, and academics. Some of the books that were suggested were the Me Book or Work in Progress, and a curriculum assessment such as the VB Map should be used as guidelines about what to teach and how to create the programs. Lastly, the purpose of this was to highlight areas of skill of a quality ABA therapist or anyone implementing ABA techniques. They must possess to develop and implement effective programming for individuals diagnosed with autism. Research as well as clinical experience has shown that when EIBI is implemented with a high degree of quality, that children can have meaningful outcomes. Both clinical experience and observation evidence has shown that children who were unable to communicate have developed conversational language after quality ABA has been implemented. Children who are engaged in high rates of aggression no longer engage in those behaviors when they are upset. And children who are lonely or depressed develop meaningful relationships after the intervention. And we have seen children become indistinguishable from their peers, all of which resulted from implementation of a quality ABA program. This ends my research for the pros section of ABA, and now Megan will introduce the next portion of our debate.
Thank you, Maria. Next, for the opposing view of ABA use is Selena Sizemore, Florida.
Hi, I'm Selena Sizemore, and I'm discussing the cons of ABA and the ethical codes that go with them. ABA is a treatment for autism that has been used for several years. ABA can be effective when used correctly. ABA is suggested to be more effective if the client receives a lot of hours a week. ABA is not like other therapies which provide less hours, less times a week. ABA is suggested to be used 25 to 40 hours per week for a client. If each client with autism requires 25 to 40 hours a week of ABA, then that is basically a full-time job for one ABA therapist. And how could then the therapist work with several cases? Also, it could be very difficult to get the parents to commit to that many hours a week, as the child will have other therapies as well. And at what point, if the client cannot agree to the amount of hours that the analyst recommends, is it unethical to provide less hours when the analyst believes that the client needs more hours in order for therapy to be effective? Another concern is if you can effectively train a BSA or RBT enough for them to provide most of the hours the client needs, or do you need to have a BCABA or a BCBA providing the hours in order to ensure the best care for the client? I know that I would want to have the most experienced person providing services to my child. The field of ABA is consistently growing at this point. This could mean less experienced individuals are becoming providers of ABA. Some ethical dilemmas that need to be considered are as follows. A therapist that provides one-on-one therapy to a client for 25 to 40 hours a week could have a potential dilemma of a dual relationship, or becoming too personally involved with the client's family. The code this would violate is code 1.06. As per the code, the therapist should not engage in multiple or dual relationships with the client or his family. This is tricky because being at the house for so many hours a week, the parents may start seeing you as a friend or even a family member because they might see you more often than they do their friends or family, or even their spouses. Code 1.02 would be violated if individuals do not have enough experience in a specific area and take a case just to help provide hours or in order to fill their schedule. This has happened to me, as one of my BCBAs that was my direct supervisor wanted to put me on a case that I was not comfortable taking, but said that it is better to have an experienced person than not have a therapist at all. If I would have taken the case, I would have violated that code directly. If an analyst recommends several hours a week for a specific client, such as, let's say, 26 hours, and the family will only commit to, let's say, about 4 to 6 hours a week, it could violate Code 2.09. Behavior analysts have the responsibility to advocate for the appropriate amount and level of services, provisions, and oversight required to meet the defined behavior change program goals. ABA can be effective, but there are a lot of things to consider when providing ABA and ensuring the best chance to treatment to be effective. These are some of the reasons ABA may not be the most effective treatment for every child with autism.
Thank you, Selena. And that will conclude our applied behavioral analysis pro and con. Next, we will go into the medical model, beginning with Maribel from Florida, which is also our group illustrator. Thank you. And I'm going to hand it over to you to lead us off for the pro medical.
Thank you, Megan. Okay, I will be discussing the medical model for ASD. And the definition would be is a psychotropic medication for the treatment of behavioral disturbances such as irritability, aggression, and hyperactivity. There are currently no medications approved for the treatment of the core symptoms of ASD. The FDA approved risperidone in 2006 and aripiprazole, which is Abilify, in 2009. Over 1/4 of children with ASD receive treatment with psychotropic medications. Rates are even higher for older children and adolescents, and for those diagnosed with comorbid psychiatric conditions. A study conducted in 2007 showed risperidone is beneficial for some features of ASD. Some first like social withdrawal, irritability, hyperactivity. There were modest changes in stereotypic behavior and inappropriate speech. Another study in 2012 showed Abilify to moderately change the irritability, stereotypic behavior, and inappropriate speech, and there were significant improvements on hyperactivity. Now we'll show a slide. Give me a second. This table shows some research that have been conducted and shows some of the psychotropic medications that are being studied. Outside, of course, there's risperidone, and then there's Abilify, and it shows the results and as well as the adverse effects. And some antidepressants and other psychostimulants that are also being studied to see if they provide any changes. This is the continuation of table 2. There's also adrenergic agents, which there's limited evidence, but given that these medications are well tolerated, they're considered second in line for ADHD-like symptoms. There's also novel agents like GABA and glutamate, which are new to ASD treatments, and research is still very new. There's still other medicines as well being studied at the present moment. Bureau et al. Made a statement that I found extremely interesting, which states, a typical antipsychotic medication ought only to be considered when behavioral interventions have been tried and failed, and when the physical risk associated with disruptive behaviors exceeds the risk of harm from medication. So from my personal experience with individuals with disabilities who have severe aggression and disruptive behaviors, many of them are actually on psychotropic medications. I would probably say that risperidone, in my experience, is the most popular. I believe in the field of ABA, we need to work with doctors to show when there are medications, if there are any improvements or any adverse changes to our graphs. Each time that there's a change of medicine, we can show if they are improving or if they have actually made it, the behaviors worse. So in the field of ABA, I think it's important for us to work hand in hand with doctors, since we do have to work with a medical model for many of our clients. And that can also help the doctor see if, the medicines can be faded out once we can actually teach replacement behaviors for these individuals with ASD. Back to you, Megan.
Thank you, Maribel. Opposing the medical model will be Jocelyn Stone and Lindsay Conroy.
Thank you, Megan. Maribel just gave you an overview of why the medical model is an appropriate treatment method for individuals with autism. She defined the medical model for you and used that definition to help promote the use of the medical model when treating individuals with disabilities like autism. Lindsay and I will now like to talk to you about reasons why the medical model is not an appropriate model to follow when treating individuals with autism. As stated and guided by the SPCE Compliance Code, there are ethical codes of conduct we must abide by as behavior analysts when treating clients we work with. One such compliance code we must abide by when looking to treat our clients is following Compliance Code 1.01. This states that behavior analysts must rely on knowledge that has been scientifically proven and derived from behavior analysis and science. Along with Compliance Code 1.01, another code that we as behavior analysts must abide by is Code 2.09, which is providing effective interventions and treatments that are based on research literature and adapted to the individual. Both of these ethical codes are vitally violated often when treating individuals with autism, and Lindsay and I will tell you how. When looking at the medical model, it does not always follow along with these ethical compliance code. According to Shaw and Mountain in 2007, the medical model makes people believe that the individual with the disability is the problem, and it focuses solely on the impairment of the individual. This focus on the impairment of the individual is why medication is often used with individuals with autism. These medications, though, are not even meant to treat autism. They are meant to treat the comorbid disorders that are often associated with it, such as ADHD, anxiety, depression. The medications are also meant to affect the core symptoms of autism, such as communication, social interaction, and repetitive behaviors. Even though they are given to help these comorbid disorders, they only help to minimize symptoms, not cure the individual of them. Shaw and Mountain in 2007 also state that the medical model assumes that the doctor has specific knowledge and expertise, which is evidence that an intervention causes greater benefit than harm. Often, these medications are given to help minimize symptoms, but they can be more harmful. They often can produce side effects that can affect the health of the individual. One such side effect of certain medications used to treat ADHD, depression, and anxiety is weight gain from increased appetite. The increase in weight could cause type 2 diabetes and cholesterol problems, which can lead to health issues in the heart if not addressed. It can also affect bone building and cause breast swelling due to hormone increases. If the behavior analyst was using an effective treatment by using food as a reinforcer, they can probably no longer use it or have to use healthier food options to make sure the client is able to maintain a healthy weight. If they are using an unhealthy food as a reinforcer while on a medication that causes them to gain weight, the behavior analyst will be violating Code 4.10 using a harmful reinforcer. The behavior analyst needs to think about the best interests of the client and make sure they are following one of the main principles in behavior analysis: do no harm. Lindsay will now tell you about a study that was done in regards to medication and weight and how it relates to the two ethical compliance codes I mentioned earlier, which happens to be the same article that Maribel used in her defense about medicals being a pro option.
Thank you, Jocelyn. I'm going to talk about the study as Jocelyn just mentioned. The study was done by James McCracken, and it was a randomized placebo-controlled study done between 1999 and 2001. The study had all the children that met the criteria for autism spectrum disorder according to the DSM-4. They all also had some form of tantrum, aggression, or self-interest behavior. All children were at least 5 to 17 with a mental age of at least 18 months. Every child that participated was not allowed to be on any form of medication before they started this study. There were 2 different clinicians who were unaware of who was actually taking the placebo and who was taking the medication, and would write down the different side effects for each kiddo. In this study, the children who received medication, such as risperidone, showed an increase in weight as opposed to the placebo group that did not change weight. We would like to show you the overall results from this study. The table is the same table that Maribel did show us, but I'm going to go over the results and the adverse effects that she did not touch upon. So in the last 2 columns, that's what shows the results and the aversive effects. Even though in the results column, it does show that each medication did show a reduction or an improvement in the symptoms it was looking to treat, the adverse effects column shows a different story. Yes, the symptoms looking to be treated improved and or decreased, but most of them had the adverse side effects, including the weight gain due to the medication. These medications could be considered effective, but in reality, they are not, since they create other effects such as the destructive and harmful to the individual taking them, because it causes the weight gain, which can cause more disorders such as like diabetes. There are other treatments for addressing these symptoms, and specifically the symptoms of autism that are not as invasive and effective without any potential harm effects. Using medication has been researched to help with ADHD, depression, which are the comorbid disorders associated with autism, but not specifically autism itself. It violates the code 1.01 for these reasons. That is, it has been scientifically proven to do just that, as it only addresses the comorbid symptoms and not autism itself. Also, if all individuals were given medication, it also goes against Compliance Code 2.09. Each individual has the right to effective treatment that is research-based and individualized to each child. If a BCBA just tells every child that they should go on medication, then this is not individualized, and based on what Jocelyn and myself have discussed, this is not a research-based intervention and is not effective. The medical model would say different because it believes that the reduction of the symptoms and the behaviors improved the individual with autism, even with side effects. That is an appropriate treatment model. As behavior analysts, though, we have to look at more than just, did this improve the symptoms of the individual? We have to look at the risks and harm of the side effects as well. I'm now going to bring it back to Megan to introduce the next topic.
Thank you, Lindsay. Our next topic, Lindsay will be starting us off, and this is the pro side to nutrition and diet model. This also will address one of the questions that was proposed by the professor, which states, what do you think are the factors that lead parents to choosing alternative interventions to ABA? Some of them can be significantly restrictive, some diets, and yield marginal results. Lindsay will now begin pro side for nutrition and diet.
Thank you, Megan. So the nutrition and diet is new and upcoming treatment for autism, and it's the gluten and casein-free diet. So many people nowadays believe that having gluten and casein-free diet is going to help the behaviors that go along with autism. This has been shown to have a positive influence. A study done by Jackie Rogers looked at the effects of kids with some form of autism that took gluten out of their diets. The article discussed how gluten could also be the cause of pervasive developmental disorder, the late onset of it. The results of the study shown in the graph showed that after 3 months of not having gluten, there were improvements in certain behaviors, as detected by the parents and the teachers who would fill out the questionnaires each day. Having a negative score on the graph will show you that it goes below the line, which shows that it improved the individual. They looked at different aspects such as social, emotional, and motor skills. Each table shows that each kiddo with a different number. The negative scores show that there was an improvement in the mean scores for each kiddo. You only see a couple letters because there was a few kids that did not finish the study, so they had to be taken out of the overall scores, which is why it's not all the letters. From looking at the mean scores, you can see 4 out of 6 of the children with autism showed improvement when having that gluten-free diet for 3 months. There was an increase in vocal communication, increased level of attention and concentration, a decrease in aggressive behaviors, an increase in affection and showing affection, improved physical coordination and motor skills, increased awareness of self and environment, and they were more calm as well as sleeping better, which a lot of kids with ASD do not sleep well. By reviewing the study, you can see that nutrition does have a positive effect on autism and decreasing problem behaviors as well as increasing behaviors that we wish to see, such as communication. There are limited side effects with deciding to do a gluten-free diet. It is said that children with autism may have an allergy to gluten, but they are unable to verbalize it. So since they cannot verbalize it, they act out in other ways to try to tell somebody that they are not feeling well. It is also said that children with autism process gluten differently, which may cause the symptoms. Because they are unable to process the gluten, they have a reaction to the chemicals, which actually leads them to acting into a certain way. By looking at the study, taking gluten out of their diet does have a positive effect on children with autism, as well as not having as many harmful side effects to the child. If someone is new to the gluten-free diet, then according to Brennan, an article I read, they should seek the help of a nutritionist so they can have a list of the foods that they actually have to avoid, because a lot of people, the gluten is tough to avoid because it's in everything. For the reasons that I have discussed, this is why nutrition is a good treatment to autism spectrum disorders. I am now going to send it back to Megan.
Thank you, Lindsay. And now for the con side, Maria Dino will address nutrition and diet. Maria?
Thank you, Megan. As Megan has stated, I will be discussing the con side of a gluten-free, casein-free diet. While the gluten-free, casein-free diet is new and upcoming, there are not many scientific studies conducted to prove that there is scientific evidence or it's an evidence-based treatment and may not be as effective as other treatments, such as ABA. In the BACB Code of Compliance, 2.09 Treatment and Intervention, a client has the right to an effective treatment. Behavior analysts always have the obligation to advocate for and educate the client about scientifically supported, most effective treatment procedures. Effective treatment procedures have been validated as having both long-term and short-term benefits to the client and society. The article that I chose was The Gluten-Free, Casein-Free Diet, a double-blind challenge trial with children with autism. In this article, it had a study. The researchers first placed 14 children with autism ages 3 to 5 on a gluten-free, casein-free diet for 4 to 6 weeks. Then over the following 12 weeks, they sent home look-alike, taste-alike snacks and meals that either contained gluten or casein, or they were gluten, casein-free. Neither researchers nor parents knew when a child was getting the food containing gluten or casein until the end of the study. This current study aimed to address some of the design issues that compromised prior reports. First, they followed children for an extended period of time, which is about 30 weeks, while ensuring that they were in a stable educational program using similar applied behavior analysis methodology across participants. Second, registered dietitians were employed to provide nutritional counseling to help families implement the diet and monitor the child and the nutritional sufficiencies of a child. Third, repeated checks were conducted on child's adherence to the diet. Fourth, psychological outcomes measures were included, in addition to the measures of behaviors with ASD and behaviors that are not unique to ASD. For example, sleep disturbance and overactivity. Fifth, the design was a double-blind placebo-controlled challenge trial. Multiple measurements were used, such as medical data from laboratory tests, ratings from parents, instructors, and research assistants. Survey data suggests that dietary interventions are used by 15 to 38% of children with autism spectrum disorder. The diet is popular among families who have children diagnosed with autism because gluten, a protein found in wheat, and some other grains, and casein, a protein found in dairy products, can worsen autism symptoms by causing inflammation in the gut, which is said to spread to the brain. This can cause problems also with anxiety, mood abnormalities, mental difficulties, and perhaps worsen the behavioral symptoms of autism. Like I stated before, the double-blind placebo-controlled study of 14 children on the GFCF diet did not detect an impact of dietary challenges on measures of psychological functions, behavioral disturbances, which were the sleep disruption and overactivity, or autism-related behaviors. While this may seem like a viable option, it is still undetermined whether or not the diet is effective in reducing autism behaviors. The most notable limitation for this study was a small sample size, and it does not provide evidence that supports the GFCF diet. There are very few scientific studies done that show that a GFCF diet is a cure for autism. Overall, existing studies yield inconclusive evidence on the safety and the worth of the GFCF diet. This ends my research for the con section of the nutritional portion, and now Megan will introduce the next portion of our debate.
Thank you, Maria. This actually concludes the pro and con side of the theoretical models of applied behavioral analysis, the medical model, and nutritional model. We addressed the first question presented by the professor through our nutritional and diet pro and con given to us by Lindsay and Maria. Now to field the second question, which was mainly addressed throughout our debate, will be Jocelyn Stone. And the question asked by the professor, what are our ethical obligations to consider other forms of intervention or support other forms of intervention in our programming? We routinely adjust according to medical intervention. What should be our considerations elsewhere? Lindsay, to you. Jocelyn, I'm sorry.
So the second question our professor posed to us was, what are our ethical obligations to alternative treatments? We discussed this a little back in our debate, and we wanted to bring back the points of ethical codes 1.01 and 2.09. Code 1.01 states that as behavior analysts, we must use interventions that are scientifically proven. And 2.09 states that those scientifically proven treatments and interventions must be effective. This means that if an alternative treatment becomes scientifically proven and shown to be effective for those with autism, then we need to be open to using these treatments. And We are ethically obligated to work in the best interests of our client in order for them to receive the best treatment and care possible. We would like to thank you for taking the time to watch our presentation, and we hope you enjoyed it.